Hello, everybody. This is Harrison. It is hopefully the last presentation for our fourth semester cardiopatho class. We're getting close. Today, I'm going to be diving into a rare but fascinating condition known as plastic bronchitis. This is a topic that isn't often talked about in day-to-day clinical settings, but when it presents, it can be very serious and even life-threatening. Over the next 25 minutes, hopefully, I'll walk you through what it is, how it happens, what symptoms we need to watch for, and what the current best practices are for diagnosis and treatment. I'll also touch on what we, as respiratory therapists, can do when faced with this condition. So, what is plastic bronchitis? Well, plastic bronchitis is an uncommon disorder where large, rubbery, tree-shaped casts, like the one seen in this image over here, form in the bronchial airways. These casts are made up of mucus, fibrin, and lymphatic fluid, and they can become large enough to obstruct major airways. Unlike common mucus plugs we see in diseases like cystic fibrosis or chronic bronchitis, these casts are thick, cohesive, and difficult to clear. The term plastic refers to the rubbery consistency and the shape. They literally take the shape of the bronchial tree. The severity can range from mild symptoms to complete airway obstruction and respiratory failure. So, what is lymph? To understand where this condition comes from, we first have to understand lymph, which is a fluid that circulates through the lymphatic system. Lymph is a clear fluid that carries white blood cells, proteins, fats, and other waste materials. Its main function is immune defense and fluid balance. It travels through lymphatic vessels and is filtered through lymph nodes. Under normal conditions, lymph drains into the venous system and plays no role in the lungs' airways. However, when there's an abnormal lymphatic flow or high thoracic duct pressures, as in certain heart defects or surgeries, it can backflow into the lungs. So we can see in this image here, this is a capillary bed, and these are the lymphatic vessels intertwined into that capillary bed. So sometimes the capillary beds have leakage. Not everything is absorbed back into the capillaries, and that leakage would cause swelling in the tissue if it wasn't for our lymphatic vessels. These can be waste products, obviously includes the proteins and the fats and the salts, um, and also pathogens, which are recognized by the white blood cells to initiate an immune response. But that's where lymph originates. It comes from the waste within your tissues found at the capillary beds. So, what is lymph doing in my airways? Well, that is a great question because under normal circulations, lymph is a fluid that is meant to circulate in the lymphatic system. So, what is it doing in the airways? Well, in many patients with plastic bronchitis, especially children with congenital heart disease, the normal flow of lymph is disrupted. This is often due to elevated central venous pressures after surgeries like the Fontan procedure, which is used to repair ventricular defects. The lymphatic vessels dilate, leak, and form abnormal channels called lymphatic fistulas that dump lymph directly into the lungs. Over time, this thickens and solidifies, forming bronchial casts. This also explains why this condition can appear suddenly, even months or years after heart surgery. So there's a video that we're gonna watch that talks more about lymphatic flow, but this is a great model of lymphatic flow through the body. It includes your lymph nodes, um, it includes the spleen, and then it shows all the vessels. This is your thoracic duct right here, and it feeds into the subclavian vein normally. So what are some other causes of plastic bronchitis? So while congenital heart disease, particularly Fontan circulation, is the most recognized risk factor, it is not the only cause. Other underlying conditions include lymphatic anomalies, viral respiratory infections as seen in our cystic fibrosis patients, asthma, and sickle cell disease. There have been rare reports associated with influenza and RSV. The key theme here is that some combination of lymphatic disruption, inflammation, and immune response tends to set the stage for cast formation. This means it's important for us to think about a patient's full history, including heart defects, immune problems, and recent infections when we see unexplained airway obstructions. This table shows different associations that can be causing plastic bronchitis. Sickle cell acute chest syndrome is one that when I was researching, I found that there is an abnormally high percentage. My mic turned off. But anyway, sickle cell acute chest syndrome, there was an abnormally high percentage of patients with this disease that got plastic bronchitis. However, they do not know why it is linked to sickle cell acute chest syndrome. That was just an interesting side note. So at this point, I would like to show you a short video that offers a visual overview of plastic bronchitis, particularly the lymphatic involvement. It shows how the thoracic duct can leak into the bronchi and how that leads to cast formation. Pay attention to how they describe the imaging techniques and treatment strategies. This visual will make the next few slides easier to understand.
This animation shows normal lymphatic anatomy and flow. Lymphatic fluid flows from the lower extremities, the liver, and intestine to the thoracic duct, which is the main channel for lymphatic drainage. In most people, the thoracic duct drains into the subclavian vein on the left side. Now, we see lymphatic anatomy and flow in patients with plastic bronchitis. In these patients, lymphatic fluid from the thoracic duct flows backwards into the lymphatics surrounding the airway. This causes inflammation and edema, or swelling, and eventually leads to the leakage of lymphatic fluid into the airway. When exposed to air, lymphatic fluid forms casts, which are thick masses of branching, protein-rich material that can make it difficult to breathe and need to be coughed out. In some patients with plastic bronchitis and a normal thoracic duct, the disease can be caused by lymphatic channels that originate from the liver, bypass the thoracic duct, and connect directly to the lymphatics surrounding the airway. Plastic bronchitis is diagnosed with lymphatic imaging. There are multiple treatment options for plastic bronchitis, including medical management, minimally invasive interventions, and surgical interventions. Our team will determine the best intervention for you or your child based on your diagnosis and imaging.
All right, so a few important things to take away from that video include the mechanism by which lymph enters the airway. We can see that it is similar to the mechanism by which fluid enters the lungs in patients with congestive heart failure, which forms pulmonary edema. We see that an increase in lymph fluid in the pulmonary circulation, also known as congestion, which increases the pressures within the vessels. That increase in pressure actually causes the lymphatic fluid to leak across the membranes and into the airways, resulting in fluid in the airways where it is not supposed to be. Unlike pulmonary edema seen with CHF, lymph solidifies when it is exposed to air, which is why we see those rubbery or caulk-like casts forming. Another thing to notice is the different mechanisms by which this congestion in pulmonary circulation can happen. We saw in the video that the most common one is a defect in the thoracic duct, which causes the backflow of lymph into pulmonary circulation, but that is not the only cause. The video also talked about congenital abnormalities in which lymph fluid from the liver drains directly into pulmonary circulation, which increases the pressure and again causes congestion to form. Obviously, each of these conditions requires its own method of treatment, which we will discuss later in this presentation. But overall, it's a great video, it's very informative, and it does a great job of showing how lymphatic flow can enter the airways. So let's talk about the signs and symptoms seen in plastic bronchitis. So they vary by severity, but the hallmark symptoms is coughing up a rubbery cast that resembles the shape of the bronchial tree. It's pretty striking when you see it. Other symptoms include chronic cough, wheezing, shortness of breath, chest tightness, and hypoxia. In some cases, there can be a sudden and dramatic respiratory decompensation if a cast dislodges and completely blocks a major airway. These cases are often mistaken for asthma or pneumonia until the cast is expelled or visualized by bronchoscopy. It's important that we don't dismiss chronic symptoms in patients with complex heart histories. So as you can see, the presentation initially of plastic bronchitis can be very similar to what we see in other obstructive airway diseases like asthma. So it's important that we look for the casts being coughed up or visualize them with bronchoscopy to solidify a diagnosis of plastic bronchitis. So how do we diagnose plastic bronchitis? Well, historically, diagnosis relied on bronchoscopy to visually confirm the presence of casts, or it was seen when a patient coughed up a cast. But today, the golden standard is advanced imagery like dynamic contrast magnetic resonance lymphangiography, or DCMRL for short, to identify lymphatic leaks and abnormal flow patterns. This imaging technique is especially useful in patients with Fontan circulation. A high index of suspicion is needed. If you see an opaque bronchial tree on imaging, think about plastic bronchitis. Sputum analysis and cast composition can help differentiate whether the cast is lymph-based or mucus-based, which can guide treatment. This image right here shows a section of MRI in a patient with plastic bronchitis who underwent DCMRL treatment. You can see all of the lymphatic fluid in the airways with that dye. So this fluid obviously, once it's exposed to air, it'll start to solidify, and you can see just how severe this can be of an airway obstruction. It functions as an obstructive process because the air trapped underneath this fluid, once that cast forms and blocks off the airway, will not be able to escape. But also, any air entering the airways will not be able to pass that cast to enter the alveoli. So how do we treat plastic bronchitis? Like we talked about earlier with that video, treatment depends on the underlying cause. Historically, patients were given steroids, bronchodilators, mucolytics, and chest physiotherapy, but these didn't address the root cause. It was like slapping a band-aid on a gunshot wound. It might stop the bleeding for a little bit, but you still are going to have all the other problems associated with it. So today, if lymphatic leakage is confirmed, targeted therapies like lymphatic embolization can seal off abnormal vessels. This is a minimally invasive procedure with high success in specialized centers. Supportive care remains vital. Nebulized therapies, suctioning, and mechanical ventilation may be needed acutely. Patients may also need dietary adjustments like medium chain triglyceride diets to reduce lymph production. This image on the right shows a normal bronchoscopy versus a bronchoscopy that could confirm plastic bronchitis. You can see the severity of the obstruction with this cast. It completely blocks off this airway. There is nowhere where air can enter the airways or exit the airways once this cast forms. So let's take a closer look at lymphatic embolization. The procedure begins with intranodal lymphangiography to map out the lymph vessels. This includes injecting a dye into the lymph vessels, which can show up on X-ray. Once the leak is identified, it is embolized, meaning it is sealed off, using agents like glue or coils. This not only prevents further casts from forming, but it also improves the long-term symptoms. Some centers have reported up to a 90% success rate with this method, especially in pediatric patients with a single dominant leak. The key is that it's targeted, minimally invasive, and treats the cause, not just the syndrome. Along with lymphatic embolization, we can do a procedure called blue bronchoscopy, where a different dye is injected into the lymph vessels that can be seen visually as opposed to only with X-ray. This image on the right shows a blue bronchoscopy, where you can clearly see the lymphatic vessels with the blue dye running underneath the tissue inside of the airways. This image doesn't show what it looks like when you have a leak, but when you have a leak, you would see the fluid coming out onto the tissue and moving down the airways. In cases where embolization isn't possible or embolization fails, surgical alternatives like duct ligation or stent grafting may be considered. Duct ligation involves physically tying off the thoracic duct, which drastically reduces lymphatic leakage by reducing the pressure within the lymphatic or the thoracic duct. to make it lower than the pressure of that within the pulmonary circulation. As you can see in this image here, these ties are used to kind of constrict the duct, and that helps lower the pressure within the duct to prevent the pressure pushing into the pulmonary circulation. This is a more invasive and higher risk procedure. Another option is stent grafting, and it's used when vascular anomalies are involved. These are rare interventions, but worth mentioning because they show how personalized and multidisciplinary this field has become, involving pulmonologists, cardiologists, radiologists, and surgeons. Stent grafting is most often used in patients with the Fontan procedure. Up to 4% of patients with the Fontan procedure can develop plastic bronchitis, and stent grafting is optimal in these patients. So, how do we manage plastic bronchitis as a respiratory therapist? So, as respiratory therapists, our role is critical. We are often the first to recognize signs of airway obstruction and hypoxia. Our interventions, such as bronchodilator therapy, high frequency chest wall oscillation or CPT, suctioning, and ventilator management, can stabilize patients until definitive diagnosis and treatment can occur. Educating the patient and the family is also important, especially about warning signs of cast formation and the need for follow-up care. Being aware of conditions like plastic bronchitis means that we can advocate for the right imaging and escalate care sooner. It also highlights why interdisciplinary communication is essential in complex cases. So, what therapies might my mic turned off again. So, what therapies might we use in patients with plastic bronchitis? So, these patients will likely require oxygen. Um, the historical management method of these patients included the corticosteroids and mucolytics, along with bronchodilators, which is something that we still use to this day to manage patients with plastic bronchitis. So, corticosteroids and mucolytics will be used to help expel the casts. If the patient is unable to expel the casts from the airway or the airway becomes completely occluded, we might take these patients frequently for bronchoscopies to remove the casts. If the patient requires mechanical ventilation, we'll expect to see an increase in peak pressures as the casts form, and then an increase in plateau pressures as the airways become occluded, lowering compliance. As airways are blocked off, we will also see a decrease in the volume delivered to these patients as there is less ventilatable space within the lungs. Modes like ACPC or PRVC are optimal for these patients, as the volume of ventilated space will change as casts are formed or expelled, and we should focus on managing peak pressures to avoid damaging these patients' lungs. Suctioning may also be useful in slowing the formation of casts, but once a cast forms, it will often be too dense and thick to suction out and will require bronchoscopy to remove. All right, so are there any questions? Anybody? Andrea, I see you falling asleep at your computer over there. Sandy, is that Fortnite I hear in the background? Ah, here's my references. Thanks, everybody.